So I'm Charlene Porcel, I'm the Assistant Director of the Robert Wood Johnson Center for Health Policy here at UNM, and it's my distinct and great pleasure to welcome back Aida Luz Giachello to the center and to Albuquerque. Dr. Giachello is a full professor in the Department of Preventive Medicine at the Feinberg School of Medicine at Northwestern University. She has an MA and PhD from the University of Chicago. But maybe most of all, she's a friend of the center. I think Aida was either the first or one of the very first of our distinguished lecturers in our lecture series here when we established the center. So it's my very great honor and pleasure to welcome her back to Albuquerque.
Buenas tardes. First of all, I really want to thank the organizer for the wonderful symposium. I really have found it extremely intellectual, stimulating. And obviously my good friend Bob, that I know him, someone was asking me how long I know you, I think from the 1970s or so. And I want to really thank the, Kaiser, that was able to plan and the logistic and making sure that I will be here, Frank. And so what I'm going to be doing today is giving you more a practical perspective about community mobilization and action based on some of those activities and projects that I have been involved most recently, some of them. I always like to say that as a Puerto Rican, I speak fast. And I have a lot to say, I go faster. And so if I mix my English with my Spanish or start talking in Spanish altogether, let me know. So that way I will be on track. But anyway, so the objective is to describe the community-based participatory research model that I've been using. And then, like I said, provide some practical example of how research and community participation or mobilization have been key interventions aimed at community and system change to address community needs. The main approach that I've been using, I decided for this presentation, instead of providing more definition of terms of social disparity, inequities, and theoretical framework, I thought that I would go just straight to the participatory action research model as a way of complementing what already had been said so nicely in the past day or so. So the model that I've been using, community-based participatory research, has several components. The first one is the partnership, the collaboration with the community leaders and other sectors. And this calls for meaningful involvement of ordinary people and key stakeholders. It embraces community empowerment as a philosophy, as a process, and as an outcome. And it really stresses what is called community capacity building. And that is done through leadership development that you facilitate and through the infrastructure building and training that are conducted with that process to be able to provide to the community and the stakeholder the kinds of tools and skills and knowledge that would allow them to really provide the kind of leadership in whatever effort that we have collaborated with. And the second component is the research. It has to be called community-based participatory research, you need to have a research project. And this could be, qualitative or quantitative, data gathering, depending on what is really involved. But assessment of needs and assets are critical in any kind of effort in working with community. And because you try to engage in localized effort, you have to, most of the time, engage in some type of data collection because the kind of data system that we have doesn't really give you the information that you may need to be able to design and plan some meaningful intervention and action. And then obviously, the third component is the action piece. You have to move from the data to social action in whatever effort you are engaged. And the community has to be clear that that's part of the effort. Obviously, there's many differences between mainstream and participatory research. Very quickly, I highlighted here. Mainstream, they tend to be more rigid. And I understand that, as a researcher, you really want to be very protective of that data collection, and you want to make sure that is collected and there is no other contamination, and we could talk about that later on. And but in reality, it's very rigid. There's no little community participation. The PI is in control, and maybe that's part of our socialization as a researcher. We tend to be always wanting to have that sense of control of the process of research. Close decision making. That means that the investigator, the PI, tend to be the one who likes to make all the decision, and usually is the one entitled to make a considerable amount of decision in terms of the research project. There's no accountability to the community. The project tends to end when data is collected and analyzed. And the partnership that you build with the mainstream type of effort tends not to be equal in a number of bases. And then the partnership, it tends to also stress community deficit. The actual research aspect tend to be more flexible, has considerable amount of community participation, and then you could look at that in a continuum. A lot of research that is being done now, sponsored by NIH, National Center for Minority Health and Health Disparity. Everybody's supposed to be engaged in some kind of participatory action or participatory processing with community, but in reality, when you really look closely about how those research are being done, they only have an advisory board that maybe is consulted in the beginning, maybe in the middle to give them some information, and maybe at the end. But there's not any meaningful effort to really engage them in decision making or to share governance or to give the community a sense of ownership of this process. So the real action in action research is when the data is collected and is analyzed. And there's also benefit for the community, benefit in terms of sharing funds. We know that the research enterprise in these countries will really support universities. And there's tremendous amount of indirect costs, so at least in average it's over 50%, 52%, depending on the institution in question. And that money and those efforts should be shared with the community. And it also can provide jobs opportunity, a technical assistance and training, and it tends to stress community asset. Now, in general, when you look at the research in this country traditionally, the research has included methods of observation, criteria for validating facts, and theories that intentionally or unintentionally have been designed to justify preconceived ideas and stereotypes of women, people of color, and of other vulnerable populations. And so what has happened more frequently than not is that it has reinforced in our society traditional patterns of power, status, and privilege. And when you talk about action research or you engage in those processes, you're trying to be very much aware of those dynamics and try to correct that for the better. So reframing the research agenda is critical. We need to really rethink what is the whole process of research, the whole purpose. And we need to be aware that the method of research as inherently scientific, objective, or useful, because we know that research is done in a sociocultural, historical context, and for that reason, we as a researcher, we bring our own biases into the process, although we try to be very objective, and we try to do that in many different ways. The research can be scientific, absolutely, but it could also be political, it could be racist, and it could be classist. And we also need to be aware that that may happen as well. And there's some time, at least I as a minority investigator have found myself that part of doing the research is trying to unlearn some of those old knowledge, particularly when you do research on Latino health, the machismo concept, the women, submissive, and all these many things that have been, done, and maybe at some point valid for some groups, but it's just unlearning many knowledge and many aspects that you realize with your new data that is not consistent with what you know about the population in question. So the research agenda has to be one of confronting issues of power, politics, and racism, because we know that attitudes and beliefs and perspective can be more important at times than knowledge. And that we need to move from research on racial and ethnic minorities to research with all by the minority group or women or whoever you're working with. Because we know that we cannot explain what we don't understand. And even I, as a minority investigator, know my limitation. I cannot necessarily speak for the Latino community in Chicago because of the differences in many different areas. So I have to even be clear, transparent to the community whenever they approach me to speak out on their behalf. And I do try to facilitate that, but with the understanding that they know that my experiences being born and raised in Puerto Rico may be completely different from the experiences of people that come from Mexico or any other country. And so we have to move beyond understanding the problem to solving the problem. And that we also have to be better consumer of research. In this country, research, everything that is published is like the Bible. People don't question it. If it's written, that means that it's absolutely truth. And we need to begin, as part of the process of even working with the students, is trying to help them to really analyze and look at those articles that they're reading and try to look at the sampling side. And in many meetings that I go, I really try to bring that into focus, because there was a couple of meetings that I attended a couple of years ago about brain development. And saying that if you don't get it stimulated, before the age whatever, I don't remember the details, that you won't be able to catch up. And then those are comments and serious researchers in this conference with NIH that they were talking about. But then it has tremendous implication of our community that is already stereotyped. And to be said that if they don't have the opportunity to the parents to be reading or putting the music or whatever, a certain nation, they won't be able to have their brain stimulated to the point that they could be able to perform well in school. So there are a lot of research that is being done with good intention. And actually that particular research was done in families in Europe. They were not even done in the United States. And then the minority research entity. Now that you see a lot of focus on establishing centers of excellence, and you see that with the Minority Institute of Minority Health and Health Disparity and many others, is because trying to develop an awareness that we need that infrastructure to be able to have minority in charge of the research process to the degree possible. That doesn't mean that other people who have the same level of understanding and sensitivity cannot be involved, but there has to be a different way of doing this, that we could be able to increase the pool of minority investigators and be able to take in consideration the sociocultural and context in which the research is being carried out. And also legitimize a lot of the work that you do. So in my presentation, and I probably have shared this with you in the past, is more sharing a practical perspective of how I particularly conduct research. And this particular church may vary depending on the particular situation. But when you are engaged in building this partnership, you need to be aware that there's a series of processes in engaging the community. And the first one starts by entering the community. And you have to, as a researcher, to be able to understand, do your homework before you begin identifying a community or going into those communities and trying to talk about partnership and research or whatever else. That you need to understand there's a series of dynamics that exists in those communities, that you need to be aware of who are the formal and informal leaders, that you have to be aware that many of those leaders have big ego. And if you contact one person, you don't contact the other, and they find out, that immediately will jeopardize you developing the kinds of partnership and effort in the community level. So there's a series of aspects of engaging in the gatekeeper, identifying those gatekeepers, working with those gatekeepers, letting them to open the doors for you. Community dialogue. After you have been able to enter this community, be able to establish a meaningful dialogue to find out where people are at and to what degree you are able to then work out, negotiate, or whatever in terms of the kinds of partnership that you're trying to build. And that varies, At this early stage, I remember I had a contract with the Nebraska Department of Public Health. They had some money to develop tobacco, a coalition on tobacco in some selected areas in Nebraska. They had high concentration of minority. And when I went to the community, and I'm very transparency. One thing that you do with the community is you're always honest, and you always, well, in my case, I don't have good memories. If I don't say the truth, I probably won't remember either. But on top of that, you have to transparency. Community leaders, they have no memories. And if you really don't do it well when you enter those communities, they're going to hold you accountable for the rest of your life practically. And so it was a matter, calling a meeting that some other people facilitated from the Department of Nebraska, Department of Human Services, and say, I'm here because I received this grant to be able to help mobilize around tobacco. Then I explained to them about the tobacco settlement, blah, blah, blah. The community said, well, we're not interested, but that's not a problem. The problem here is teen pregnancy. So then it just, how then you begin in saying, well, you know what, if teen pregnancy appears to be a problem because I did revise and look at some of the data and it's true. So if you help me with the tobacco aspect, I will make sure that I will give you the kind of support and we could collect data simultaneously on teen pregnancy and develop a work plan. And so that's how we developed a good coalition, and then it was divided into major committees, those interested in teen pregnancy, and the other one, that there were some that still were interested in tobacco. So those are examples, you know, of how, for example, you could build that. Another project that I worked very quickly, because it's not part of the samples that I'm providing, but it was the building a genetic coalition, education coalition in Washington High, in New York City, in Washington High Dominican community and an African American community. And so Marshall Dine had this contract from HRSA. They really needed to bring a community together, because that's what the priority or the initiative was all about. They had no idea where to get started, so they approached me to help them in the process. So again, the whole process is the same. You identify who are the gatekeepers. So we identify some key people in those communities that were either affected directly or indirectly by genetic related condition, and that at the same time were interested in being the convener of that first community dialogue, because they don't know who I am. I just came from Chicago. And so they were the one who then wrote a letter of invitation, and they were the one who set up in one of the hospitals, I remember this particular meeting. And then once you have the people there in that dialogue, is then telling them honestly what is the purpose of the meeting. Why is it that genetic education is critical? Knowing, as I knew, that genetics is not a priority for those communities. They're interested in jobs, you know, as public safety, gang-related activities, substance abuse, but genetics was not in the top of their agenda. So it's just a matter of discussing. I was sharing that with someone at the table a few minutes ago. It's a matter of discussing with them about the fact that the science is so advanced in the area of genetics that if they are not aware of what's happening, as community leaders, they have a right not only to be on top of some of those issues, but to be able to know that there's benefit in terms of new therapy that will be emerging for prevention and treatment, that there are opportunities for them to protect their community, because when all that information about genetics begin to go out, if there's not appropriate safeguards, those communities will be further stereotypes. So just bring them the understanding of the importance of the topic in question. And so in that meeting that we had about 28 people, immediately we were able to have people committed to establish the coalition that is now called the Washington High Gene Evaluation Project. So so you define the problem with them, get them involved in. Once they're willing to do the partnership, which could be in the form of a coalition or consortium or whatever you want to call it, then it's a matter of engaging in the whole aspect of group dynamics, building trust, being able to articulate group goals, being able to provide them with the understanding of the importance of working collectively, and then be able to engage them in just simple processes. The way that I usually do when it's new people that I haven't had a history working with them is basically that we purposely organize meetings during lunchtime, for example, because food is very important. You probably know that, particularly working with vulnerable population and community of color. Food has to be part of whatever you do in your meetings. And so in those meetings, we told them we're calling a meeting for 12 o'clock. We're going to start with a light lunch, and then we're going to go into discussing the issues that the agenda or whatever we have provided them ahead of time. And so in those brief discussion during the lunchtime is when you start knowing the people more closely. If they're married, they're not married, they have children, the issues, and you start connecting at the personal level. Because when you work with community and you work in partnership, the personal relationships are very critical to be able to connect, to be able to sustain those kinds of relationships, and then later on move them into the research process. So all this is in terms of step number 2. The 3 is the capacity building. You want the community to be equally knowledgeable as you are about the topic area. So educational opportunities for those coalition members. I call it, if it's diabetes, diabetes 101, diabetes 201, because you want them to be the expert on the topic area. They're the one who's going to be the spokesperson of the community. They're the one who's going to be involved with the media interview when that happens. They're the one who really need to be, to level with us, that we are, as a researcher, we don't have any expertise other than what we have done and what we have read, etc. But they are the true expert because they live in those communities. They're the one who are suffering for the kinds of problem that's being studied. And then you also engage them in the applied research method by, once there's a discussion about what is the problem, and we then ask them what you want to know that would help you to improve and solve the problem in your community. So the development of questionnaire has to be with the types of questions that they need to deal with the issues and the solution that they want to have. And they're the one who needs to then engage in the instrument development. We obviously do ethical IRB, related training, and other capacity building in terms of different research methods, whether it's focus group, whether it's a survey, whether it's probability sample, that we have to then not use the jargon that we use in research, but try to put it at the level that people may understand. Community are very bright. They come up with wonderful ideas. It's just a matter of letting them to articulate it in their own way, and us the opportunity to listen. And then once we do the assessment and the data collection, whatever the different methodology that the group have agreed, then engaging obviously in the dissemination of the preliminary findings through community forum, town hall meeting, furthering reorganizing the partnership of the coalition, and begin then a focus on action plan. And sometimes the action plan can be conducted before the community forum, and then you refine the action plan based on the added information with the strategies and the kinds of activity. And then you always have an evaluation component to see how well you are mobilizing there. So for me, capacity building in the literature is building infrastructure. So a coalition itself is an infrastructure. It's something that is there that hopefully will be sustained, or programs, services, training. And like I said, training in the area of the topic of area of interest, in methodology, information dissemination, and advocacy and policy. All that is part of the training activities that are conducted during the duration of the project. And so the first sample is one that I call it samples of community-initiated research, because there is this perception that it's us that always goes to the community. But in my experience, community also comes to me, particularly if they know me or heard about me, or they feel that somehow I could be helpful in whatever problem that they need data. And so the first one is the Blue Island Environmental Justice Project. And then I'm going to be talking about Hispanic health initiative, and hopefully we'll have time to talk about the multi-level intervention with the Chicago Southeast. The environmental health project at Blue Island, the community approached me. This community in Blue Island is a working class community affected by air quality due to an unresponsive industrial site, which was called a Clark Oil Refinery. And some of the chemical polluting the air produces genetic changes, cancer, affect the reproductive system, and can also lead to hallucination and many other respiratory problems. So this particular sample poses the question about who defined the research problem to be studied, whose interests the research serves. What are the benefits of the research to the community? And so Blue Island community residents were experiencing immediate some respiratory problem in the form of asthma and some other conditions that they were sharing as a result of the petrochemical industry in the area. And in October 21st of 1987, an explosion occurred at the Clark Oil, increasing residents' air pollution symptoms and concern. And so they approached me, and I, as a person that is very honest, I said, listen, I have no expertise in environmental health. You will be better off, and I gave them names of people from the School of Public Health and other people that could help them and do a better job, because you need to be honest about your limitation and how far can you help. They left, and about 2 weeks later they said, no, we talked with some of the people, but we still want to work with you. And so I always open my eyes and I said, well, this is a window of opportunity to engage them in, health disparity research, look at social determinant, in this case, environmental issues. And so the way that I always pose those kinds of approaches is that I tell them, well, if you teach me about environmental health, then I will be able to facilitate you learning and understanding better about the research methods and helping you with the data that you need to collect. And I do that on purpose because you want to level the field. You don't want to position yourself as being the expert that know better than them. Because in reality, the community, from my perspective, knows better. And in this case, they knew more about environmental issues than I. Obviously, I could have spent a couple of days and read a couple of articles and become knowledgeable, but it's just leveraging, it's just developing that equal relationship with them, that they have a lot to offer. There was no money involved, and some of the initiated research has the money involved. So the community needed data to document the problem and get policymakers' attention. They just were not able to get the attention in their, of the political leaders and the Environmental Protection Agency. So we applied the approach of participatory model, and they were able, as a result, to collect more than 500 face-to-face survey with about information of 1,100 individuals in the community. So the key partner was the Good Neighbor Committee. That was formed in 1996, nonprofit organization. They advocate for health and social needs, and including environmental justice issue. So we immediately engaged in a community forum because I needed to know if other people had similar concerns to those that came to talk to me. And then in that forum we were able to identify volunteers who were then going to be doing the training, who were then going to be trained in instrument development, interviewing, data collection, data entry and analysis as we go through that stages. And this happened like in October, and once we did the training and the survey and everything was ready to go based on the kinds of questions that they wanted to be included, then suddenly I said to myself, would they do it? Because Chicago is getting cold and it's difficult to do face-to-face survey when the weather is not that cooperative. So I was surprised that 3 months later they came with all the survey, and so immediately, most of this thing in terms of training is where I get a lot of the students involved to help them and build the capacity and to monitor the data and the quality. So a lot of things opportunity, because I'm always looking for opportunity that the student could be involved in public health related issues and learning and working with communities and developing that wonderful experience and satisfaction in doing that. So the results of the survey indicate serious health problems that were associated with air pollution. 68% of the residents reported illness and symptoms of illness. Illness and symptoms of illness vary by census tract. The percentage of illness related to environmental pollution varied from 40% to 80% depending on where the person was, the family or household were living. If they were close to the petrochemical, they were most likely to be affected. And so the other thing that they decided to do after the data was analyzed, and again, all this is a process of capacity building. Let's sit down in a table here. Let's see how we're going to be. What does this information mean? It's helping them to understand all the processing. And so they say, you know what? We want to have a press conference. We really need to share this not only with our community, but with the public at large. And so immediately then the role that we had in the center is to help them to prepare for a press conference. The messages, the press release, mobilizing the media, the listing of the media that they want to, in those areas to be involved, et cetera, et cetera. And obviously the logistic of that. I personally didn't go because I believe that when the community has ownership of a project and they're the one who have done all the work, they are the one that should get whatever credit or whatever, you see, so I decided purposely and I told them about that. And so there were all kinds of media. This is only an example of some of the articles that came out because it was one of the few environmental health projects that were conducted, although the data was not a probability sample, it was a convenience sample, but it was one of the few studies that were able to demonstrate some of the impact of conditions of this nature. And even later on, I got even a call from the National Institute of Environmental Health and Sciences. They want to give us money to do then a larger study building upon that because they heard about our effort. And so, then moving then, once we develop the report and the fact sheet, we usually, for dissemination to the communities, bilingual fact sheet, although most of the people here were not necessarily Latino, it was a working white, although it had maybe 1/3 or less of Latino and very almost none were African American. And so engaging, in community education about how to deal with some of the symptoms and the illnesses that were emerging in those communities, and then engaging in the policy and advocacy work. So after they did the press conference, they were able to secure a pro bono lawyer who were able to take the case. We found out there was all kinds of sweet deals with the Illinois Environmental Protection Agency. The federal government has to get involved. There were all kinds of violations that that particular petrochemical industry were engaging. So there are all kinds of things that led to a class action suit. The good news, and the reason why I'm sharing this, despite the fact that it started a little bit earlier, is the fact that we just heard in September 22 of 2011 that there was a settlement check. There was more than $60 million given to that community, that everybody would have share, based on a number of other considerations of how much money they would get as a result of the lawsuit. And so that's why I wanted to present that, indicating again that when there's community action, that when there's will, when there's data, because in this country, data, people want to see the data. Whenever you say there's a problem, people don't take you seriously at the community level unless their data, although it was not the best data, but it was enough for them to build the case and to be able to collectively mobilize and engage in a class action suit. The second case is also a community initiated. This is much shorter. For lack of a better word, we call it the Illinois Manacled Initiative. The background was that the former governor of Illinois met with a group of Latinos. And that was part of his negotiation, for lack of a better word, during election years. And so they promised a group of Health and Human Services organizations that they would provide over $1 million or more so they could engage in program and services. Obviously, you probably know who the governor I'm referring to. But the governor's office requirement was to make sure that there would not be too many political and controversy with the money they were giving to the Latino group. They wanted us to have good data and a plan to justify the political decision. So again, this is with the group of organizations that were involved in this effort. The various from Rebaño Compañerismo, which is a faith-based group, to a hospital, to Illinois Migrant Council, because we had to collect data across the state of Illinois. Again, with no money involved. Only the people having a strong will and commitment to be able to collect data so they could be able to access those resources. And so we engaged in the same similar processes. There were over 2,253 face-to-face interviews with people over the age of 18 and older. Again, we trained the community-based organization staff and volunteers. We developed, a version of the CDC Behavior Risk Factor Survey that we thought that at that time would be helpful for the kind of information they needed. We developed field operational manual and data collection protocol to make sure that we could standardize the data collection and that we could be able to somehow provide the best possible data under the circumstances that it was, another probability sample and selected communities throughout the state of Illinois. And so there were a field supervisor and coordinator who was a community professional volunteer that was willing to then have those weekly telephone calls and discuss any issues emerging from the data collection activity or any other challenge. So what happened? When you do community, particularly initiated research, there was some unexpected circumstances. The governor was accused of corruption, and that was in the media. Because they wanted to sell the President Obama former Senate seat. And you know that, and he's actually in jail right now. And there were all kinds of many other violations. So then the challenge here, if you have a group of people that really invested so hard in this kind of effort, the challenge here was how can we keep this group together so the project will be completed, and how can we develop new goals and objectives? So again, group dynamic strategies to get them to be energized again, because they were all depressed, upset about all this matter. And they really liked the governor. The governor was able to establish a very good relationship with the minority community, African American and Latino, and so this was a shock. People were in denial. It was unjust and done to this man. But anyway, so the whole issue was that once new goals and objectives were developed, and the goals were, listen, you have this valuable data Why don't we just take this opportunity once we finish the report that all of you are reviewing and develop the work plan, and why don't we come up with a policy agenda? How can we then be able, as a result of that, meet with the Illinois Latino Caucus, meet with the Department of Public Health at the state level, the Chicago level, Cook County level, meet with all these other agencies. They have resources and they need to know the kinds of data, because although I'm not presenting data, but the data indicated more than 60% of Latino did not have health insurance, for example. So many of them got involved in many of the efforts that I'm also involved in, others in the Affordable Care Act. And so there were all kinds of things that they gave them the opportunity to be spokespersons of the group and articulating the many findings of this survey, and to be able to then, because there was a policy agenda that was developed with clear recommendation to be able to provide that to those policymakers. And they were able to be instrumental in a number of policy initiatives. From the creation of the Latino Family Commission, there was at that time a concept that emerged, from Health Disparity Commission, from other kinds of legislation to standardized collection of race and data. So there were all kinds of things that emerged from that effort, and the group is still on working in some of those agenda items. The third one, I may have presented this in the past, but it's the Chicago Southeast Diabetes Community Action. Targeted six communities of the low socioeconomic status located on the far southeast side of Chicago, reaching the Indiana border. And until the 1980s, those communities depended on the U.S. steel industry. And those jobs are no longer there in reality. So community experience not only unemployment, but also a series of diversity of health problems, from HIV, sexually transmitted diseases, infant mortality, you name it, in those communities, including environmental pollution because of all the steel mills that were being closed. So again, there was a funding from CDC, that there was an announcement to apply for an application. So the process that we follow with most of the application is call a meeting. We always like to convene the meeting. So we call a citywide meeting saying this money are available. There's a possibility that we could apply if all of you are interested and willing to work with us. But you need to tell us of all the 7 priority areas that include cancer, diabetes, hypertension, HIV, infant mortality, you name it, which of those areas you feel that is of top priority in your community. So again, getting them back to decide in priority areas that needs to be focused based on the guidelines, obviously. Getting them to decide which community area. And so it took a couple of meetings for them different leaders from different part of the city saying you should come to Humboldt Park or Pilsen because of this problem, or someone saying no, we should come over here. And so one of the persons that were attending those meetings, Margaret Davis, an African American, she said, Aida, we're in the far east, in the border of Indiana. No one wants to do research with us, because we're too far from the academic institution, because somehow we're not attracted to them for whatever reason, because it's heavily African American and Latinos, and sometimes some of the investigators may not be interested in those types of Latino or those types of African American. And so that's how we develop a coalition of African American, because I do work often, very frequently, with both African American and Latino, as I believe there's more commonality than differences in terms of culture, socioeconomic status, access to care, and a whole laundry list. And I'm trying very hard to build those partnerships that are critical as both populations are growing very rapidly in our country. And so the number of organizations, there were about 30 of them, included health and human service organization, business, minority professional organization, including the Black and Hispanic nurses, because we try to bring professional group back to the community to serve as role model, but also to engage them in whatever we are doing in those communities to subcontract relationship. And then obviously people living or at risk for living with diabetes. And the goal in this case was reducing diabetes disparity. So the multi-level ecological model is presented here in this logic model. The first phase was helping the community understand the causes and the solution to the health disparity reduction, in this case related to diabetes, that it's not by accident that those communities are saturated with fast food. That it's not by accident that they are designated as food desert. I mean, in Chicago, around that time, 40% of all the community, we have 77 community or neighborhood, 40% were designated as food desert. Now everybody's talking about food deserts, but at that time when we started, there were no one really addressing that. So engaging them in capacity building and training and nurturing those relationships further, engaging them in what I call action planning, and then, you know, the formation of the coalition, which is that circle kind of in the middle, and then developing the community action plan after they decided to engage in data collection. The data collection included a survey, probability sample, telephone survey, but included more than 10 focus groups with African American, with Latinos, Latino who speak Spanish, don't speak Spanish, women, men, stratified in so many different directions, including community mapping, so we would know where the grocery and the stores and the school and everything was at. And what we found out, it was only one street they had all the business, which is the commercial street, if you know about Chicago, and South Chicago particularly. And so then engaging in intervention. The intervention was capacity building as an intervention, because people felt they needed more skill, more knowledge. And the whole idea of training community health worker was critical in everything that we did in those communities. So training the community health worker to not only to become effective diabetes educators for management and control of diabetes, but also effective in assessing the grocery stores, you know, through an assessment tool that we developed. And helping the grocery store to the chambers of commerce that were working with us about how can they position the grocery items so people will be able to find what they need for diabetes-related condition, get them to, you know, make available those items, get them to increase fruit and vegetables in those communities, because of the preliminary finding indicate that the consumption was very low. So a lot of capacity building, but also capacity building of the coalition in terms of policy. We engaged them, we got the computers at the university, community leaders, and now I'm calling community leader or community resident. We have people that were homeless. They were very much involved in our coalition because we always had food, and they were hungry and homeless. And those proven later on as we got to connect them to be effective community health workers. So we had some of them in the African American and Latino community. Once we assessed their skills and their ability, they were bright people. They just happened to be in circumstances. They were homeless, and because the faith-based community partner were serving many of them, in our coalition meeting, we always had a group of them sitting next to the physician and the nurses and other community leaders. So it was interesting, but it was extremely valuable to be able to provide that kind of, you know, of setting where everybody is equal in addressing similar problems. And so community and system change. And so to do community and system change, you have to engage your partner in what CDC calls system thinking. What is the contribution that everybody from different sectors can provide in solving diabetes-related problems and cardiovascular-related condition and other tobacco use was also related to the efforts. And so one of the things was the healthcare system, the school and housing, the business sector, working with the food industry. So that's one, and I'm going to be elaborating that in 1 minute. And then the other intervention was community awareness and education campaign, heavily with the media, but developing a whole series of educational material. And the other intervention is the diabetes self-management program for lifestyle changes and protective behavior. And all that's supposed to be supposed to lead to reduction of disparity and change in risk and protective behavior. Obviously, the target group were primarily people living with diabetes, so we wanted to include people who are already working with diabetes in all the effort, and we had our work plan included a number of strategy. People undiagnosed, because 50% of the people with diabetes don't know they have diabetes, so we needed to figure out a way how to link them to service and get the screening. The population at risk, which we thought that everybody was in population at risk for being minority, and then population with no known risk. That although CDC was not happy about us including them, we wanted to get the community support to change those community norms, and we needed them as well. And so, you know, a lot of coalition meeting, the food you could see to the left side, and people coming with family and children, and again, African American and Latinos. So building capacity building, I already mentioned some of the many, in the case of advocacy, we trained them how the government work and how the legislature work. And we did mock training with some of our political partners, elected officials that came, and then we had a whole series of practice. And I have 10 minutes left. But anyway, thank you. And then, so training was very heavily done. Then the Diabetes Self-Care Center is a capacity building infrastructure. We had a center run, once we trained the community health worker, it was run by the community health worker with, in partnership with the local schools and colleges in the area, bringing students in public health and the School of Medicine and many others and social work to be able to learn about public health approaches. And the Diabetes Self-Care Center was there, a center, kind of a one-stop shop where people get screening in partnership with the hospital for eye, food, nutrition, dental, etc. We had an incentive program, a gift shop. We have a telephone hotline that we were not able to implement for many other issues. The ultimate goal was a home health care that was developed actually more recently in the last 2 years. Psychosocial support and intervention, technical assistance and training, financial assistance for Medicaid and Medicare, and then a series of community health promotion, walking club, diabetes screening, nutrition, exercise, the diabetes education classes, the understanding about home remedy, how that may interfere with medication, insurance information, etc. So this is a model that already have been duplicated for other communities. And also in the aspect of improving access, it was working with the hospital to provide continued medical education on clinical guidelines for the management and control of diabetes, because most of the people were being seen in the emergency room or were hospitalized. Very little outpatient management education was taking place. We have patient exit interview to make sure the physician actually learn about those clinical guidelines. It's surprising how community physicians don't know about any guideline, whether it's asthma, whether it's diabetes, gestational diabetes, you name it. They just don't have the time to really be on top of those guidelines.